everyone. Welcome and thank you for joining us for today's session on frequently asked questions on newly diagnosed multiple myeloma. My name is Mary DeRome. I'm Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I am joined by Dr. Gurbakhash Kaur and Ms. Sonia Patel from the UT Southwestern Medical Center in Dallas, Texas, and Don O'Connor, who is one of their patients from Fort Worth, Texas. We have a number of questions from patients and caregivers about initial treatment, maintenance therapy, and monitoring for newly diagnosed multiple myeloma. So let's get started. Okay, so let's talk first a little bit about induction therapy options and supportive care. Dr. Kaur, for a patient who's just been diagnosed, how do you and the patient decide on the best course of treatment? For example, do specific test results like the presence of cytogenetic abnormalities influence the choice of a particular regimen?
Thank you, Mary, for having me and Sonia on this webinar. Yes, so there are several initial tests that have an implication on how we end up selecting the regimen. Prior comorbidities, existence of neuropathy actually does play a role as well. But most importantly, it's a cytogenetics. Anybody who has high-risk cytogenetics, that is the T414, deletion 17p or TP53, even amplification 1q, we tend to use quadruplets, such as DVRD versus a triplet. And it also, we use beta-2 microglobulin, albumin, and LDH along with the cytogenetics to stage the patient. And the higher RISS3 and 2, probably particularly, we use a quadruplet. Although I think more and more myeloma community has moved towards a quadruplet in general. I think that's, for the most part, that's what guides us.
Mm-hmm. Yeah, I think that's what we've heard too. And I was going to ask you that question, but I'm glad you clarified, because I do think that, the more you talk to people, the more it seems like quadruplets are becoming the new standard of care up front, whether or not you have high risk cytogenetics, right? So, and I've heard that from a number of folks. So, Sonia, what about patients who have a precursor condition like monoclonal gammopathy of undetermined significance, or MGUS as we call it, or smoldering multiple myeloma? Those patients just want to know why they don't require treatment. And many comment it's just really hard to sit and wait. So if you have a patient who has one of those conditions, I mean, how do you counsel them about, what their course of what they're going to be facing for the next few months?
Sure. And thank you for having me today. I'm thrilled to be here. To answer your question, currently there's no data to support treating these underlying conditions will actually cure their disease or necessarily delay progression to multiple myeloma. Luckily for many, patients remain asymptomatic with these conditions. And it's also important to note that not every MGUS will necessarily progress to multiple myeloma. If and when they do, it can often take several decades. Mm-hmm. Although it is difficult to sit and wait, like you say, we want to avoid any unnecessary treatments for as long as a period as possible, just given the potential of side effects. When someone does start on treatment, it becomes a lifelong commitment to ensure the disease stays well controlled, and we want to avoid interruptions in treatment in the future. I often counsel patients in letting them know that we will be monitoring these precursor diseases closely with routine labs, imaging, bone marrow biopsies, visits at specified intervals, and it often helps to review their specific disease criteria and their assigned risk based on this to help reassure them further.
Mm-hmm. Mm-hmm. Can you talk just a little bit about like the frequency of visits of like an MGUS patient versus like a smoldering patient?
Certainly. When we first meet, we have specific lab values, data that we want to monitor, and it assigns them to a specific kind of risk category. Mm-hmm. Typically with our MGUS patients, we feel comfortable monitoring them every 3 to 6 months, that first year of meeting them. If that's stable, then we can go to annual lab visits with them. For smoldering multiple myeloma, we were wanting to monitor them more frequently, maybe every 3 to 4 months, and be monitoring these values closely.
Great. Thank you for answering that question, because that's a question that we get, fairly frequently, actually. So
Mary, I just want to add one thing. Sure. To this, and it's, Sonia is very right. With smoldering myeloma, we do watch and keep a close eye on early on to see what's the rate of rise in their parameters. And
Mhm.
if it's stable, we can even go to 6 months, for certain patients who have low risk. And, there's a whole 2-20-20 criteria that we use to sort of
Sure. Mhm.
assess risk status with that. And while there is some debate in the myeloma community right now, whether to treat high risk myeloma, and certainly there is one trial that does support the use of lenalidomide, there's several ongoing trials. So at the present, Sonia and I do not treat MGUS at all. With medications,
Mhm.
we observe, and smoldering myeloma, high-risk myeloma is the only one where we will treat in the setting of a clinical trial. But outside of that, we observe.
Yes, right. Okay, great. So let's go to our patient, Don. So glad you could be with us today, Don. Can you tell us how you were diagnosed with myeloma, and how were you able to connect up with this amazing treatment team at UT Southwestern?
I do have a great team, that's for sure. So the way that I was diagnosed was I was on vacation and tried to lift the suitcase into a taxi cab, but my back hurt too bad I couldn't even lift up a suitcase. So then I went to my primary care doctor to try to figure out what's going on. That led to a spine clinic where I got some steroid shots.
The usual, right?
Yeah, they didn't work. Then luckily though, the senior surgeon at the spine clinic, after the first set of shots that didn't work, he contacted me and he said, I think we need to check you for cancer. And it was just like that.
Wow.
And I was looking at backache, and all of a sudden he says, check you for cancer.
Mm-hmm.
So that was startling. And I talked to everybody that I could. If I walked down in the hall at work or at the condo, I would ask if I thought those people were in the medical business.
Mm-hmm.
What should I do? What should I do? And it came out, find a hospital that has a specialty, the hospital for multiple myeloma. It was, don't go down to your local just general oncologist in a small town. Find a specialist. So I'm in Fort Worth, start doing my research, and it gave me 3 choices. I ended up with 3 choices: MD Anderson, UT Southwestern, or the Mayo Clinic. And the one was going to require, 2 of them are going to require a lot of travel.
Mm-hmm.
But I first contacted UT Southwestern, trying to get in touch with Dr. Anderson, and he said he could see me in 4 months. Well, at this time, I had 7 broken vertebrae at this time.
Oh no, my gosh.
2 months prior, I only had 2 broken vertebrae.
Mm-hmm.
So I'm thinking by 4 months, I'll have everything will be broken. I can't wait.
Yeah,
So
right.
Followed through with the contact for Dr. Hyman at the Mayo Clinic, and we were going to set to do that. But the next day, then I got the call back from Dr. Kaur to come here, and she'll treat us right away. And I say us because my wife is pretty much every step of the way, except for right now. She's not here with me. She's gone to get my medicine at the Walgreens.
Oh, there you go. She trusts you to talk to us.
Yes. So after all of that, we came up with came up with the plan, and I was hooked. I needed to do something quick because I thought in my mind that it was going to get bad really fast.
Yeah. So how long did it take between the time that you actually, like the doctor said that you need to be checked for cancer, and then you were actually diagnosed with myeloma?
As soon as he said that, my primary care doctor came to I couldn't leave the house. By this time I was in a wheelchair, and the primary care doctor came to the house, did blood work, sent it off. That was the week before Easter last year. And so that would have been end of middle of April. Mm-hmm. So then by the following week, they said all the blood works come back. We can't prove that it's cancer, but the blood work says we can't disprove it either. Mm-hmm. So we think you need to make the next step, mm-hmm. which then by May I was there. I was able to get in to see the doctor, and Dr. Kaur said, the tests aren't in, but I know what I'm doing, and this is multiple myeloma. And she was right, of course. So
I bet that made you feel
didn't
much
take-
better, right?
Oh yeah, I still have a very confident and capable doctor. So
Yes,
I'm
that's
happy. So
good for you.
maybe total 6 weeks at the most.
Okay, then that's not so bad, right? So, but so Dr. Kaur, I mean, you know, and with Don's history, right? I mean, having vertebral fractures like that is actually like it's not a rare occurrence for myeloma patients. I mean, how many, like out of the patients that you see at newly diagnosed stage, how many of them actually present with that as like their first sign?
I have myeloma is just not one disease. I would like to say it's multiple diseases. And there's recently many people who've been commenting on that, because while many of my patients do come with, fractures, whether it's wrist fractures, vertebral fractures, hip fractures, there's some who don't actually have a single bony lesion. So there's a heterogeneous presentation, but I would say more than 50%, 50 to 60% is, patients end up having some kind of bony involvement in my clinical practice. Now, that's heterogeneous and all that. I think we're getting a connection issue for a second.
Yeah. I know I think it's the weather here in the Northeast. Nothing's good here today. It's this nor'easter we got going on. Okay. So knowing, Don's history and his case. So when you have these bone lesions and you have treatment of induction therapy, right? Does that help the pain, or do the bone lesions heal completely after you begin the therapy, or do you have to give other treatments as well?
Well, along with induction therapy, whatever may be, induction, you have to control the disease, and the disease is with, anti-myeloma therapy, with a monoclonal antibody or a proteasome inhibitor like Velcade and IMiD. So along with dexamethasone. So you have to control the pain. Symptom control is at the mainstay of treatment. You have to control the disease, and there is healing, although not all the time completely, because there's, and then third thing is sometimes I do palliative radiation if I just know that the pain is unbearable, and we have to get fast control, and just the treatment's not going to kick in right away, pending patient symptoms. And we also do anti-resorptive therapy with either Zometa or Xgeva. Usually I like to do that for 2 years once a patient is diagnosed. So, the treatment of vertebral fractures or just bony disease is multifactorial.
So, Sonia, aside from bone fractures and pain, what other symptoms that are caused by the myeloma do patients frequently experience? And then similar to with the bone lesions, once you start treatment, do the symptoms actually go away?
Some common other symptoms that patients may present with initially include fatigue, weight loss, sometimes lower immunity, and at times neuropathy. A lot of the time patients are presenting with symptoms associated with anemia. That's extreme fatigue, shortness of breath when they're exerting themselves. And these symptoms can improve after treatment's initiated, given that the anemia often resolves. However, just by nature of the chemotherapy agents that we use, fatigue can be a side effect of those, so that it doesn't always go away completely. In particular, as we mentioned, we use steroids as part of our regimens, dexamethasone. Usually people who are 70 years or younger, will give them 40 milligrams weekly. If they're 70 years and older, this can be reduced to 20 milligrams weekly. And some people can often have what's called a dexamethasone withdrawal, where they go from being very awake, alert for an extended period of time, and then kind of sort of crash and become very fatigued and low energy. So it's important to check in with our patients frequently to see how they're tolerating the dex and address their concerns of insomnia, fatigue, and see if any dose adjustments warranted. You also have to be careful with monitoring their blood glucose levels, as steroids can raise this in certain individuals or make underlying diabetes worse. So we have a great team of endocrinologists that we use to help treat blood glucose if we feel like they're trending upwards. Also, Revlimid, an oral chemo agent that we use, a lot of people will have fatigue with that, some diarrhea, constipation, at times rash. So we're constantly managing these side of symptoms supportively as they arise.
Sure. So it's really just a lot, right? There's a lot going on there.
A lot, yes.
So Don, once you were diagnosed, what was the initial treatment that you received and how did you decide on that treatment? And did you get a second opinion when you were trying to make your decision?
So my first, after diagnosis, the very first set of treatment was, Dr. Kaur thought that I would fit well into a trial. So this is a trial, and I don't know all the right jargon, right? Triplets, quads, whatever. But this, for my trial, I was doing the dexamethasone, the Revlimid, and the antibody DARA. So those were my three medicines. And once we got in a couple of months, then we started to add in the bone medicine, the Zometa, to try to keep things going. But so she told me that was the plan, that was going to be the plan, and that was how it was laid out. It just so happened that I had kind of the last video meeting scheduled with the Mayo Clinic lady to decide if I was going there or staying at UT Southwestern, and I explained the test and the trial to her, and she said, "Sounds great." She said,
Oh, there you go.
This was my biggest surprise of the whole process, I think. And she said, "I really like what you're getting into. I wouldn't come here if I was you." That's what she told me. She said, "You'll be much more comfortable at home. You're welcome to still come here." And I thought, wow, that's a great plan. And if she agrees with it and UT Southwestern agrees with it, then that's the one to go through.
So which Mayo were you talking to? Was it the one in Florida?
Minnesota.
You were talking to the Minnesota one? Wow, that would have been quite the trip, right? To go up there for treatment.
But the spot I was in at that point, I'd have gone to Panama for some type of treatment. I needed something.
You needed something. That's true.
Yeah,
that's true. But being in all that pain, that could not have been like a good thing at all, right? So
no,
it's just bad.
No.
Okay, so let's see. Dr. Kaur, many patients believe that a clinical study is only for patients who've run out of options, but clearly you've put Don on a clinical trial, like for his first therapy, which is pretty amazing. That was his initial treatment. So should all patients be asking their care teams about clinical trials right after diagnosis? Is it appropriate for all patients?
Yes, I think you should always be asking your providers or your doctors and your team about what are all the options. You want to get the best opinion and the most open opinion. Granted that the therapy has to be tailored to the individual. I think that's often the misconception, that trials are often sort of the last resort and there might be a placebo, and and that's why my first meeting with my patient is, in fact, Sonia and I spend a great deal of effort in our first meeting, because that is where we lay the foundation of our relationship with the patient. And trust is an important aspect of that. That is probably the most, and competency and obviously trust, those two factors. And I think we established that with Don very well when I said, "Come here, we're going to figure this out, we're going to treat this, and I'm not going to delay your treatment because you need it." Because you, like he said, I would have gone to any place. There was a sense of urgency, which I noted with his, given what was going on with him. And also I think when it's newly diagnosed, the stakes are obviously higher. You're not going to offer a treatment that's the clinical trial has to be well thought out as well. It's at the moment, DARA, the trial that we have is a MRD risk adapted trial. So DARA has been in treatment for almost close to a decade now. Not there completely, but close there. Revlimid has been around for 15, 20 years, and dexamethasone, and along with Velcade. So these are proven therapies. We're just sort of sequencing them to understand who are the patients we're overtreating and undertreating. Right. And Don is young, and there weren't any high risk features on his bone marrow. His staging was stage 1, RISS1. So we felt very comfortable having that discussion. And even outside of that, he would have gotten either DVRD or VRD, depending on what we chose. And so I think because we had that foundation and that trust, Don came on board. It didn't take a lot of convincing to actually do that. Right, Don?
Correct. It didn't take long to to trusting the care team.
Oh, that's good.
Yeah.
And other patients, appreciate your efforts, Don, because this is how new therapies get approved all the time. So patients have to go on trials, and that's how these things become standards of care. So,
Sure.
yeah. So, Sonia, many newly diagnosed patients who may be watching are about to start their induction therapy regimen. So, let's talk a little bit about what patients can expect. This is a broad question, and your answer might be different depending on the regimen that any patient will be receiving. So I'm going to ask you like a series of questions. But so in general, first question, how often will a patient have to come to the hospital or clinic to get treated?
Sure. So we've mentioned that induction therapy can often include either 4 drugs or 3 drug regimens, and they're usually completing about 4 to 6 cycles in total before making a decision to go on to stem cell transplant, or if ineligible, some kind of maintenance therapy. Each cycle consists of 4 weeks in total. Many of our regimens use an oral drug, like we've mentioned, Revlimid. You take that 21 days out of the cycle, but also weekly dosing of some drugs that are usually administered subcutaneously, so an injection. So a common one that we've talked about is the daratumumab. It's given weekly for the first 2 cycles, then every other week for cycles 3 through 6, and then given monthly with cycle 7 onwards. Another one, Velcade, also given subcutaneously. That's given weekly 4 to 4 weeks for the first 2 cycles, and then it can decrease to 3 to 4 weeks starting with cycle 3 onwards. So patient can be expected to come in quite regularly in the beginning for induction therapy. They're also expected to come in and see a provider at the start of each cycle to check and assess how they're doing, and also how they're responding to therapy by monitoring their markers.
Mm-hmm. So you mentioned a couple of subcutaneous administrations, so Velcade, and of course Dara is sub-Q, right? Which is just like such a great advance after, instead of having to do anything IV, right? Correct. So because IV really, when you're doing an IV administration of any medicine, it can take a long time. And can you talk like if, before Dara became subcutaneous, how long did the treatment with Dara take when you had to have it infused IV?
I think it was several hours. Wasn't it upwards of 6 hours? Or it was a very long time frame. So yes, it's dramatically decreased the amount.
Now it's like, what, 5 minutes or something?
Yeah, exactly. Yeah.
Much better.
Yeah.
And so when you're getting that sort of like an IV treatment, if you're on, say, something like Sarclisa, which doesn't really have a subcutaneous administration yet, is that something that patients need to have a central port to be able to take?
No, we rarely, if ever, arrange for a central port.
So it's kind of just like it goes into your hand or whatever, right?
Yes. Yeah. So.
And if you're doing this type of IV or really any kind of treatment, like you're getting a subcutaneous infusion or an IV infusion, do you need to have someone with you at your appointment just to make sure that you can get home okay? Like you wouldn't give people these medicines then expect them to drive home.
Well, correct. I feel like caregivers are really essential, especially for that initial consultation. We're giving a lot of education about the disease, how we monitor it, how we manage it. So it's a lot to absorb. So it's helpful to have that person there taking notes and taking that all in. And for the first few infusions, they can be a little bit longer in length because we're delivering chemo drugs that may warrant monitoring for allergic reactions or unwanted side effects. So it's helpful not only to have company for those longer days, but also to have someone present in the event the patient needs assistance getting home, if they have fatigue, nausea, vomiting, headache, fever, anything like that. I think with time, however, these infusions should reduce in time and sometimes frequency, like we mentioned, and a patient becomes just better tolerating the treatment and acquainted with the process. And so making a caregiver not as necessary for each visit down the line.
Okay, so now let's talk a little bit about autologous stem cell transplantation, because this is a very common standard of care therapy for newly diagnosed patients. So we know that following induction therapy, the typical next step is treatment with an autologous stem cell transplant if you're eligible. So Dr. Kaur, what is the purpose of a transplant, especially if a patient achieves a deep response with their induction therapy?
I think stem cell transplant still has an important role in myeloma therapy. Compared to all the newer therapies that are coming on board, it's going to be very cheap and effective. The point of a stem cell transplant is to get you a deeper response, and we know deeper responses translate into longer, duration of a response. And while we know from the determination data that there's no overall response, overall survival benefit when you do upfront versus delayed transplant, there is a 20-month PFS benefit if you do upfront. Now, when we decide on how someone becomes eligible, we take into several accounts: their age, their other medical conditions, their preference, obviously, right? Someone who is 50 or 60 years old, they can possibly delay transplant because they'll be eligible at the age of 65. Give me 1 second? I think my Zoom disappeared. Do you guys still see me?
Yes, we do.
Yes.
Okay, I will keep on talking.
Okay.
But I don't. So I mean, those are the factors that we look at. I hope I answered your question. I don't want to keep on going. What happened here?
Okay, now we're coming back.
Yes, now we're good. Sorry, I totally got distracted because my screen disappeared. So once again, to finalize, the purpose of the transplant is to have a deeper response and to achieve MRD negativity. That is one of the newer, there's recent data that's coming about MRD.
Great. Okay, Sonia, can you walk us through how patients should prepare for a transplant, and then also what their caregivers need to prepare for before and after the transplant?
Sure. So in the beginning, patients should be prepared to have many, many appointments as they undergo what we say eligibility workup for a transplant to ensure they meet the criteria. So they'll have an echo of their heart, they'll have function tests that assess their lung health, they'll have a bone marrow biopsy, urine studies, blood work, and they'll also have frequent visits with our transplant coordinators, social work, dietitian, insurance coordinator, just making sure everything is lining up. Once this workup is complete, then they have the opportunity to meet with Dr. Kaur or their doctor and the transplant coordinator to review all the workup and make sure everything is in line. This is also a great opportunity for the patient and the caregiver to have ask any of their questions and go over the results and overall plan. They then prepare for the stem cell collection, where they'll get 4 days worth of injections that help stimulate their bone marrow to produce more of the stem cells. They then come to our infusion wing at the clinic and undergo the collection that takes on average between 2 and 3 days. And it goes through sort of a blood filtration system. Once it's completed, the product is preserved by our blood center care team, and it's stored until reinfusion happens at the hospital. So after the stem cell collection is complete, the patient, caregiver, they'll have to prepare for the hospitalization. On their first day of admission, that's when the patient will receive a high-dose chemotherapy that kind of drives their disease in a deeper remission that standard dose therapy alone can't accomplish. And then their stem cells are reinfused following this. The patient can be expected to stay in the hospital roughly 2 weeks, at most 3 weeks, to allow for their bone marrow recovery with close monitoring and managing their symptoms, making sure infection is well controlled or whatnot. I'd have to say the caregiver is a very, very important role during transplant. We encourage caregivers to help the patient with all their needs, and especially transportation, coming to the educational visits, learning the process as a whole. We do require a caregiver for the first 30 days post-transplant. About half this time, as we mentioned, they're in the hospital, but once they're discharged, they're coming twice weekly for visits, for monitoring. Also, the caregiver is helping them eat, drink, monitoring for infection, staying active. They're their biggest advocate. They let us know if anything is coming up, and they help with managing medications, grocery, preparing food, cleaning the house as the patient is recovering during this acute kind of time period.
Great. So we had one patient. This is like a really interesting question that I had never received before from a patient on one of our webinars. So the patient wanted to know if there was any incidence of administrative errors during stem cell apheresis, storage and administration. So basically, how often are stem cells after they're collected lost, expired, or given to somebody else, or any other kind of procedural error? Does that happen?
Not to my knowledge, no. We've
I
never
mean, I
had
would
any
imagine
instances.
that people are like really, really, really careful about what happens
Yes.
with these cells, right?
100%.
They check and then they check and then they recheck to make sure that everything is like where it's supposed to be and everything's labeled and
Right.
the right person is getting the right bag of cells. So
Yes, 100%.
okay, that's kind of what I thought too. So I guess, but people have to ask these questions, right? So
Yes.
It's a very valid question.
yeah, I mean, right? I mean, these things happen. I mean, it's not that it has like probably never happened, but it's extremely
Yeah.
rare, right? So
Yeah, but there's lots of checks and balances, and
Sure.
that's why
Yeah.
when the patient's cells are infusing in the room, there's a presence of nurses, the blood care team at our center. Every center probably has a different process, and there's double checking of the bags, verifications of the medical record numbers, data parts. So it's
Yeah.
like
Mhm.
there and no interruptions or distractions during this time, and there's a set time. So every center has its checks and balances in place. So because this would be a big error if it's to happen.
Yeah, I would say. So
We're not
Don-
trying to jinx me, I hope.
No. No, we're not. We're not. So it sounds like you're getting ready to have a transplant. Are you planning on having one?
No, but we did stem cell harvesting
Oh, okay.
right at the first of the year in case in the future
Sure.
we need to do it.
Okay, good to know. Is that part of the protocol for the clinical trial that you're on?
Yes.
Okay.
The trial, in my mind, the way that I explain it to myself is that it's kind of a performance-based trial, and as long as I'm performing according and my numbers are meeting targets, the goal is to give me as little bit of medicine as possible to get me where I need to go, and that way the side effects are minimal, and there's options for the future that way. So it was, as long as I met my targets along the way, and the biggest target finally being an MRD negative reading. Once I got to that point, I was able to get out of induction and then move to the next phase, which was going to be either harvest your stem cells and keep them and freeze them, or take them out and put them back in after the chemo. So we're sitting here now with a couple 15 million stem cells at the blood center and
Nice.
waiting,
Good.
hopefully, to never use them.
Luckily, they last for a long time, so
Right.
you'll be able to use them in years if you ever need them. So it's a good thing to have in the bank.
Yes.
So, Dr. Kaur, you talked a little bit about eligibility criteria. So we don't have to go over that again unless you want to. But so if you're found to not be eligible for a transplant, then what do you then treat patients with?
So then we treat based on the Maya trial with the Dara, Revlimid, dexamethasone. That's the standard of care in the U.S. I tend to not, and these patients tend to be usually elderly. So then I try to spare them of the Velcade, especially given the neuropathy risk with it. So my go-to regimen is DRD. Now, of course, when I get frail patients, and I would start with one drug and I would add. So everything is, you assess the patient in front of you, not necessarily an algorithm that you follow. So DRD, continuous treatment, is what we sort of follow for the transplant ineligible or deferred transplant approach.
Okay, so let's move on and talk a little bit about maintenance therapy and minimal residual disease testing. So Dr. Kaur mentioned that he was tested for MRD after his induction therapy was complete. So then if we're going to ask a few questions about MRD. So basically, what is MRD testing, and do you have to get a bone marrow biopsy to be tested?
So MRD is minimal residual disease. It's actually currently the deepest way of assessing response. I sort of give an example of the iceberg, right? You see what's on the surface and then you don't see what's underneath. And bone marrow, when we say somebody has a complete response or a SCR, we're not totally at the deepest level of assessing the response. And currently it's mostly in clinical trials. MRD obviously is moving to clinical practice. The implications of that are still, being debated within the myeloma community.
Sure.
But 10 to the -5 or 10 to the -6 is usually what we go for. And we use an NGS. There's two ways to do MRD assessment. One is by flow-based, and the other one is by NGS based. And we currently use the NGS method. So Don had it after 6 cycles and he was MRD negative. So he did not have to have an escalation in his therapy with the addition of a 4th drug. So he de-escalated. For my patients who are MRD positive on this trial, I add a 4th drug, Velcade, and we do that for a certain amount of time. We assess response. If it's MRD negative, we de-escalate. If it's MRD positive, we actually add, that's when they go for transplant. So it's a risk-based assessment. And currently, I tend to do MRD. My first assessment is usually post-transplant to assess what's the deepest level of response they have achieved. And then I monitor them periodically. And yes, you do need a bone marrow biopsy. There are current, I've certainly in certain patients have done blood-based NGS testing. And I have some preliminary data on that on a very small cohort. But you may not have enough disease in the blood to be picked up.
Yeah, it's
so
not
that's
as
why
sensitive to do it that way. That's what I've heard.
So peripheral blood is not the most reliable because if it's negative, it doesn't tell you a whole lot. If it's positive, it tells you that you're going to relapse. So the go-to site of testing it is actually bone marrow.
So is MRD testing I mean, you work at a major academic medical center and folks who work there use MRD testing all the time. But if a patient was going to like a community practice or just like a standard doctor's office or a hematologist oncologist in the community, is MRD testing more of a standard there as well or not yet?
No, I think it's mostly used in academic centers. And I often tell people that, our goal is to get MRD negativity, but it has to be sustained MRD negativity. And the information that I'm gathering from MRD negativity is not going to make me not put you on maintenance therapy or de-escalate that. But, one of the biggest challenges in myeloma is actually we don't know which patient to do continued therapy on and which patient to de-escalate therapy on. And I really think that MRD will have a space in that. If you, let's say, have sustained MRD for a couple of years or 3 years, there was an abstract at ASH that alluded to this, then possibly you could consider de-escalating. So I think that's where the role is, but mostly it's done at academic centers.
Right. So I definitely saw that at ASH as well. So it's interesting. It'll be interesting to see what what these studies are going to show about discontinuation of therapy after achieving MRD negativity. But MRD negativity really is the goal of therapy at this point. As if you can administer the test and you see that you're getting a negative result, then you've achieved your goal, at least in the short term, right?
Yeah. Yes, that would be the goal. But, we have to be practical. What happens at academic centers cannot always be applied to community centers. Financial reimbursement for the test is a big challenge as well. So, for that to become widespread, there has to be solid data. And I think that's what the myeloma community is trying to figure out.
Sure. Yeah. Insurance is just a huge issue. We don't talk about that enough, but it's just you guys have to deal with that on the front lines all the time, and it's just it's hard.
Yes, it is very hard.
Really hard. So Sonia, aside from MRD negativity, can you tell us what other responses to induction therapy patients might achieve, and then how is response to treatment traditionally measured?
We typically follow criteria by the International Myeloma Working Group. So we'll look at how their markers have responded to therapy. So Dr. Kaur just mentioned complete response for that matter. That's when after treatment, we've noticed that there's an absence of the monoclonal protein in both the blood and the urine. There's no soft tissue plasmacytoma. If they've had a bone marrow, it's less than 5% involvement. If we're following their free light chains, then it's a normalization of that ratio in addition to this criteria. To make this a stringent complete response, it's all of this criteria plus having no clonal cells by bone marrow aspiration. For those who've had a very good partial response, we're seeing a 90% reduction in either blood, urine, monoclonal protein. And again, if we're following their free light chains, it's greater than 90% decrease in the difference between the involved and uninvolved free light chain levels. Then there's partial response, where it's more of a 50% reduction in the M protein in blood and urine, or if they've had at least 30% plasma cells in their initial bone marrow, we're seeing at least a 50% reduction post-induction therapy. Then minimal response is even a little bit further down, where it's between 25 and 49% reduction. And then lastly, there's stable disease, where they don't meet criteria for any of the above, and it's continuing to be about the same.
Yeah. Then things get hard. Okay.
Yes.
So Don, are you on any therapy right now? And if so, what are you on? And then let us know how you're feeling with it.
Yes. So we're in the maintenance section of the trial. So in that, the maintenance program, I'm still doing the same 3 drugs from the original induction phase, except a lot less dosages of each of them. And so now I do the DARA and the DEX every 2 months. And then I still do the Revlimid every 21 out of 28 days, except it's a reduced dose of that
A lower
as well.
dose. Yeah.
Yes, and then they because of the fractures, we've added in the Zometa, and that's in every month as well. So it's much better now than going every week or every other week. I get
For sure.
to stretch it out to every month. So
I can imagine.
yes, it's been good.
So good. Are you feeling any side effects from what you're taking right now?
This month, no. That's maybe one of the harder parts now, is that for me, each different month, I would never know. Sometimes it's constipation. For January and February, it was really dry skin, which I'd never had before. But there's plenty of different potential side effects, and I imagine I'm going to run through them all before it's over.
Maybe.
But I think the thing that got me more excited than anything was that from the time we started treatment, I could feel myself getting better almost every day. I felt, I feel better than yesterday. And you do that for months, and you really get a really good positive outlook.
Yeah.
To the point where I got a call from one of the local support groups, because I signed up for it, but I never did anything with it. And he called and he said, well, you're on the list, but you never join in or do anything. I said, I am just selfish, is because I really don't want to know what's going to happen, because I feel so much better than yesterday. I don't want you to tell me that in a year it gets worse. I don't want to know that, because I'm so much better than I was. So,
I can kind of see that, so
yeah,
it's good. It's good. So Dr. Kaur, what Don is on for maintenance is not really like what you would, say standard of care. I mean, he's taking Revlimid, right, which is the standard of care, but then he's on a couple of other things too. And this is probably just the result of the clinical trial that he's on, right, which really prescribes what he should be taking at each step. So can you talk to us a little bit about maintenance therapy and some of the standard of care? We know there's an approved standard of care, but there's also other regimens that people use for maintenance.
So yes, Don is on the maintenance regimen per the trial, and he's going to get an assessment once he completes this. And then if he's negative, he's going to move on to probably only one drug of those of that regimen. Traditionally, the standard of care is actually Revlimid, 10 milligrams continuously. That is usually what ends up being given as maintenance therapy. Oftentimes we have to tweak the doses based on tolerance. Many patients post-transplant actually have a very hard time tolerating Revlimid due to cytopenias or GI toxicity. So you end up, tweaking the doses, possibly 10 milligrams for 21 days, 7 days off, sometimes even dropping down to 5 milligrams. You can do that. Some of other regimens that can be used for maintenance therapy but are not as common is actually Velcade, particularly if they have T414 translocation. I try not to do Velcade-based maintenance as much as I can because many patients end up getting neuropathy from Velcade, and I think that's actually one of the most challenging side effects to deal with in respect to in a myeloma patient's journey with myeloma. They live many years, and the neuropathy is the most bothersome. But you have to. I don't do twice weekly Velcade. I also do only once weekly Velcade for that reason, actually. And and even based on Griffin or even Forte trial, doublet-based although the data behind doublet-based maintenance therapies is not so solid, but it has been done in clinical trials for Forte and Griffin. So in a selected patient, depending on how many high-risk cytogenetic markers they have, usually those are the patients you would consider a doublet-based maintenance therapy, or actually even patients who have sort of primary refractory myeloma, which it takes, those are the patients I would consider that. But generally, go-to thing is Revlimid.
Yeah. So speaking of Revlimid, Sonia, and Dr. Kaur said that patients often have trouble with taking Revlimid, and they have some bad side effects from that. So especially, cytopenias, right? So low white blood cell counts and low platelets while on therapy. So what can you offer patients who have these side effects from Revlimid?
We often have to give things like a granulite site colony stimulating factor. So in other words, Zarcio, where we're stimulating the white blood cell, or platelets get too low, then we're having to hold the Revlimid along with the anticoagulant that they're on. But we do use sort of a stepwise approach. If we feel like these dose interruptions are happening more frequently, we'll go from 10 milligrams continuously to just 21 days, or we'll further dose reduced to 5 milligrams, and we can even extend the cycle to 35 days. So offering a 2-week break rather than just the one.
Okay. Oh, that's good. So, so Dr. Kaur, let's talk a little bit about second primary malignancies with long-term use of Revlimid. And that was, there were several talks about that at the fairly recent ASH meetings back in December. So are all patients who are on Revlimid maintenance at risk of these second primary malignancies? And if so, is there anything that can be done to lower that risk? So, from what Sonia was saying, like the timing of the maintenance, taking breaks from treatment, or like dose reductions of Revlimid, does that actually help with that?
I think it's not just Revlimid alone. I think it's possibly the combination of melphalan and Revlimid, because melphalan is an alkylating agent. So I think the combination of those probably increase the risk. When we counsel patients on maintenance therapy, we discuss all these possibilities. And you're at a difficult place at that stage because you want this cancer to stay in control. You don't necessarily want to worry about the next one. But we do a very good job of basically guiding the patient in terms of screening. So make sure that their colonoscopies are done, mammograms are done, they're going to the urologist, they're going routinely for their skin care check, and going to their dermatologist. So Sonia and I have a very holistic approach to this. We can't prevent everything, but we try to stay on top of the healthcare maintenance part. And most of the time, if oftentimes we more than the primary care, sometimes we're on top of it, and we're telling the patient, you need to get your colonoscopy done, or you need to get your mammogram done. So we try to counsel it that way.
Okay, that makes sense. Okay, so we're getting quite close to the top of the hour here, so we're going to wrap up. And my final question for all of you is going to be, what advice would you give to a myeloma patient who is navigating initial treatment options? So Don, I'm going to let you answer first.
I would say to find a clinic or a hospital, or at least find a doctor that's really familiar with the multiple myeloma. I think, as you said, the clinic or UT Southwestern having some different resources than what some community centers would have. I think those are, that if you can manage it, if you're close by, that's a great option to add to your thing. Then the other one is to watch out for all of the statistics. Once you start doing your research, when you first get diagnosed, there's all kinds of things you'll find on the internet.
Yeah,
and
sometimes better not to look, right?
Right, but you're gonna find it. It's just one of the once you find it is when you quit looking.
Yeah.
Like, I don't want to know those anymore. But the thing is that those numbers are the statistics are old, because it takes
It's
that whole
true.
range of time.
It's true.
To create,
it really is.
right?
And they don't, I mean, even the ones that people use routinely, like the government statistics, et cetera, they're only up to like 2018 or something. And that's already like 5 years ago, right? A lot happens in myeloma in 5 years. So it takes time for the statistics to catch up with the therapy advances that happen in myeloma literally every year. Yeah.
And then the other one is just, you're going to end up cashing in all of the goodwill and all of the honeydews that you've done in your life with your caregiver, because they are so important to the process. So it's like I said, my wife is not here because I didn't have enough. We're on vacation and I didn't have enough medicine, so she's gone to the Walgreens to get it filled while I'm here with you guys.
So that's great. It's a great story. Yeah. Caregivers are really important, right? So helpful.
Yes.
Sonia, what advice would you give regarding navigating initial therapy for a newly diagnosed patient?
I think it's important to keep in mind, although there's currently no cure for multiple myeloma, there's so many treatment options, and overall the prognosis for someone diagnosed with this type of cancer has dramatically improved over the last several years. Patients are living longer, and it's really truly kind of like treating a chronic disease now. But given this, patients need to understand that they will be always on some sort of therapy. So even if they do go through induction therapy, have a transplant, and our maintenance therapy about 3 months post-transplant, patients can sometimes struggle having to go back on some kind of treatment at that point. But it's really these agents that are helping lengthen their remission or deepen their response and keep their disease well controlled. So,
Okay, Dr. Kaur, the last word. What is your advice?
Well, first, I want to thank Don for joining. This is great service that you're doing while on vacation.
Yes,
so we absolutely. Are very appreciative of that.
We are.
You're welcome. I owe you way more than this.
Oh, thank you. I think the main message is don't be afraid to ask questions, and you should never feel bad about getting a second opinion. And I tell that to my patients. It never hurts my ego if you go and get a second opinion, because it's your body. So I think getting a second opinion, getting another person's perspective on your disease is always something to go along. And all the things that Sonia and Don mentioned, that caregivers are important. This is a chronic disease. There's lots of therapies. There's lots of hope in myeloma. And then that's what we're at a point where we didn't have enough good therapies. We got them. Well, now maybe we're overdoing it, and maybe we're underdoing it. And that's the process where I think we're going to make the biggest impact in terms of research. Who are the patients we de-escalate therapy? Who are the patients we escalate therapy? And I think this is where the future sort of is going to be.
Yeah, I agree. I mean, actually, at this past ASH, there were a number of studies which were looking at de-escalation or even stopping therapy altogether after, you know, a number of years of being on maintenance, et cetera. So we'll see how the data plays out. It'll be interesting about, you know, with how things go, considering all the new therapies that we have. And, you know, it certainly is a very hopeful time in myeloma. There's certainly many, many options for patients, which is a great thing. So on behalf of the MMRF, I'd like to thank Dr. Kaur and Sonia Patel and Dennis O'Connor for joining us today for this Facebook Live. I really enjoyed our discussion. I think that many patients are also enjoying the discussions that we have. In response to some questions that are just sort of popping up on my screen, we are recording this session and it will be available on YouTube. And we'll send out the link to that so that everybody will be able to watch it again if they weren't actually able to watch the whole thing. So I'd like to thank those of you who were here live to watch the program on Facebook. And I'd like to thank our sponsors of this program, Adaptive, Genentech, GlaxoSmithKline, Janssen, Karyopharm, and Takeda. Without their support, we would not be able to do these programs. So, and if you have additional questions about what you heard today, please call our MMRF Patient Navigation Center. Their phone number is 1-888-841-6673. They are available from 9 o'clock in the morning till 7 o'clock in the evening Eastern time. These are oncology professionals who will be able to offer you answers to your questions and also any resources that you might need. So again, thank you for watching, and we'll see you next time.
Thank you.